Okay. Yeah, I decided, I've been waiting for a while here. I wanted to talk about malaria. And you might think of what's the big deal with malaria? Because, it's not really an infection control concern. We really don't worry about it with hospital epidemiology or anything. But it's just a cool bug. I've really gotten to like it, which is kind of surprising to me because I've always considered myself a bacteria guy. But malaria has just kind of been fun to deal with lately. So I'm going to talk about malaria, and you have to give it some respect. Look at the numbers here. These are the latest numbers from the World Health Organization. You're still talking about 600,000 people dying every year from malaria, somewhere around 250 million cases of malaria around the world every year. So there's a lot. There's a lot of malaria out there, and it's always been a huge, huge burden. This graph is just showing you that these countries here really popped up in the last year between 21 and 22. And if you look at it, it can be more specific than just that. In 2022, we had 608,000 deaths around the world from malaria. 76% of those were in children less than 5 years of age. This is really a disease that kills young children. Not so much older folks after they've had some exposure to it. No one ever gets full immunity to malaria. You can get malaria over and over and over again. You're never going to get full immunity, but the severity of the disease will decrease as you get older. When I first taught a class of malaria, I had some students from Sudan in the class, and they would tell me that, yeah, it was difficult to get through childhood. If you could get through childhood without dying from malaria, then it became something that was kind of an annoyance more than anything else. You would get it, they said they would get it a couple times every year. You learn to recognize the symptoms. You'd go down to the clinic and they'd give you the drugs. It was never officially diagnosed, but they'd give you the medicine and you'd be fine with it. But one child under the age of 5 years dies every 68 seconds in Africa. And you can see this map here shows you that of children under that age dying, in some places 30–40% of all the deaths in children less than 5 are because of malaria. So it really is a disease that hits children more than anyone else. I threw this in here just to kind of show there's this tremendous economic burden. Some of these countries have a difficult time with their economic development because there's so much money that has to be spent on malaria. So a big economic burden, not just to households, but also to entire countries. I'm not going to really go over that table any. And then just to show you, this is in 2021. These are among the countries that report to the World Health Organization. You can see all these countries in white do not even report their numbers because there's not a whole lot there. But Africa is certainly the place that's going to be hit the hardest. But there's a significant amount of malaria in Central America, South America, and Southern Asia as well. It's not like the United States totally escaped. This is a very famous paper. This is cited a lot to show that the United States used to be an endemic area for malaria. This was a really, the methodology here may not cut it today, but in 1915, they sent out surveys to physicians in these 8 states and did some finagling of the numbers and came up with the idea that in those 8 states, over 600,000 people a year got malaria. So you'll see this widely cited as saying that in the United States, we used to have more than 600,000 people in the United States who would get malaria every year. That's not the case anymore. But if you look at our numbers, the numbers are going up. This line here at the top, this solid blue line, is the total number of malaria cases reported per year to the CDC. And you can see that that is steadily going up, increasing. This hash line, hyphen line, whatever, is the number of people who are actually U.S. residents. So you can see most of the cases that are shown are in U.S. residents, and that is also going up. We're hitting about 2,000 cases a year in the United States. But almost totally imported. You go someplace else, you get it, and you come back and you're diagnosed with malaria here in the US. So if you look at it, malaria in the US, the greatest risk is going to be to those Americans who travel overseas to endemic areas, to Africa or to South America or Southern Asia. Those people are going to be at risk for acquiring malaria and may bring back here and be diagnosed in the US. So we all know that if you go to any of these countries where there is endemic spread of malaria, you take your medication. There are various drugs here. I can't tell you anything about those drugs. That's for pharmacy to deal with. But those are some of the drugs that are commonly given for prophylactic medication for people traveling to endemic areas. And which choice is going to depend on some things, whether you're pregnant, what country you're going to, the timing. Some of these drugs, all of these drugs, you have to take for a certain amount of time before you leave, and you have to continue taking them for a certain amount of time after you come back. There's some variables that go in there in choosing which medication you're actually on. But you should, if you're going to any of these endemic areas, stay on that medication the entire time you're in the country. You'll also see things like this, while traveling, avoid mosquito bites, long pants, long sleeve shirts, bed nets. They always say stay inside from dusk to dawn. I kind of look at that and say, honestly, if I'm taking my lifetime trip to Africa to go on a safari and, it's 110 degrees and we're getting in the Jeep to go see the elephants in the moonlight, I'm kind of going, so take the medication, but then try to do these other things as much as you can to avoid exposure to mosquitoes. The reason it's a severe case for us is because we're basically a child immunologically. We're like these children in Africa who are getting malaria for the first time. There's no immune protection whatsoever, and therefore the disease can be very severe. An adult American is not the same thing as an adult Tanzanian. We do have great concern when people come back from endemic areas with malaria. Here's the life cycle. I'm not going to go through the whole life cycle. It take a long time to get through this whole thing, but the key situations are going to be right over here. When you first get infected, when that mosquito injects that organism into your bloodstream, it infects the liver cells. And it's going to go through this process here of growing and multiplying inside that liver cell. Once it ruptures from that liver cell, it infects the red blood cells. And then this cycles. This goes on and on and on. These guys, when they rupture, they infect more red blood cells. So this is the process right here that is going to give you the disease malaria. This is where you're going to see the symptoms of it. And then eventually, another mosquito comes up, it pulls up these gametocytes, this form of the plasmodium, the protozoan. And then it goes through various stages in the gut of the mosquito. That's the short picture of it. There are lots and lots of different species. It's all caused by plasmodium, but these are the 4 that are the main causes of malaria in humans. Those 4 right there. We'll show some pictures of those coming up. There's also a bunch of species that cause malaria in monkeys. One of them is Plasmodium knowlesii, which we kind of have gotten in the news lately because that one has kind of crossed over into humans. So this is only in Southeast Asia, but there's some situations, where a monkey goes, I'm messing up. A mosquito goes and bites a monkey, picks up those gametocytes, picks up that organism, and then comes and bites a human. And you can transmit that particular species right there. But believe it or not, we're not the only ones who have to deal with malaria. There's all kinds of mammals, birds, and reptiles out there that also get their own special form of malaria. It is important to know which species it is you're infected with, because the prognosis and the treatment is going to differ based on it. We worry most about Plasmodium falciparum, the most severe form of the disease, and it's also the most common species that we see out there. Most cases of malaria that we see are going to be Plasmodium falciparum. The reason it's most severe is there's 2 reasons why it's the most severe. First of all, when it comes over here and infects red blood cells, it can infect any red blood cell. So it can just go hog wild, do a whole bunch of red blood cells, and you can get a very high level of parasitemia. A high percentage of your red blood cells can be infected by this organism. That's not the case with the other species. Plasmodium vivax can only infect reticulocytes, very young, immature red blood cells. Plasmodium malariae can only infect old red blood cells. So the level of parasitemia is never going to be very high with those. Plasmodium is going to have the run of the house. Sorry, falciparum is going to have the run of the house. And the other thing about falciparum is that this stage right here, you don't see those in the peripheral blood unless the patient is really, really, really sick. You don't see those in the peripheral bloodstream. These forms get sequestered into capillary beds. So you won't see those in the circulating bloodstream. But by getting in there and adhering inside those capillary beds, it can block them, and that leads to infarcts. You'll get cerebral malaria, where you'll have these infarcts form in the brain. You can have placental malaria in a woman where the blood supply is cut off to the fetus. So the main complications, the most severe complications that we see in malaria are caused by that sequestration of these forms into capillaries. Now, on the other hand, falciparum is not the most difficult one to treat. The most difficult one to treat are really going to be vivax and ovale. And that's because they're the only ones who are capable of perpetuating this liver cycle. When this thing ruptures and releases all these new parasites, they can go and infect another liver cell. Now, what that means is that you can have a fairly long-lasting asymptomatic stage. This form of the parasite is called a cryptozoite. So it's possible that you could go to Central America, get infected with Plasmodium vivax, come back to the United States and not really have symptoms for months or even a year later. Theoretically, it's possible that if you don't kill off the cryptozoites during malaria treatment, you could have a relapse. They could come out later. If you read the textbooks, you'll often see them say it can come out decades later. I've been told by the malaria experts at CDC that that's not true. It may come out a year later, but it's not going to be decades later. So a little harder to treat. It requires more treatment. You have to make sure you're not just killing the parasites in these blood cells, but you also have to kill off the parasites that are in the liver. So they're a little bit more problematic to treat. As far as the symptoms of malaria, this is the thing that causes all the problems right here. You have these parasites. They form all of these little things that I'll call merozoites inside this red blood cell, and that's going to rupture and release all these parasitic antigens. So you're going to have this kind of allergic type response to these parasitic antigens. And in the case of falciparum, where you have a lot of your red blood cells that could be infected, you could really have a decent anemia from that. So the symptoms: chills, fever, sweating, the classical picture of malaria, this paroxysm where you get fever, and then you kind of fever drops off and you go into chills and sweating. That's kind of a classic picture of malaria. Is it cyclical? We'll always talk about different species having different cycle times. This one is 48 hours. This one is 72 hours. And that's what you're going to see in the movies. I swear, every time I see malaria in the movies, that's exactly what you see. It's what you're going to see a lot in adults in Africa. For us, you're really not going to see a cycle. We don't have the antibodies there that are going to kind of regulate that cycle a little bit. So as a result, in immuno-naive Americans, you typically see just a simple high static fever all the time. But then there's all these other things: headaches, muscle ache, tiredness, black water fever from the hemoglobin that's passed in the urine, and all these complications that can occur from it. Like I said, falciparum, typically the most severe, and it is going to be more severe in immunocompromised individuals and in non-immune individuals, which really means most of the people that we're going to see coming in our hospitals with malaria. So who needs to get tested? Any person who's gone to an endemic area for malaria transmission within the past year. Not necessarily have you just come back 2 weeks ago, but have you come back in the last year? If they're showing signs of malaria, fever, chills, headache, it's really common to have fever in a returned traveler. Malaria needs to be one of those things. I've been told, I don't have data to back it up, but in those research projects where they looked at this, that one of the most common causes of fever in a returned traveler is actually dengue. But malaria is another thing that you need to kind of look for. Whether they took all their medication or not, the medication is not 100%. And when people tell you they took all their medication, they're not 100% truthful either sometimes. You want to test. The only way to definitively say that this person's got malaria is to do laboratory testing for it. And you want to start treatment and treat well as quickly as possible so that you don't get those complications. So let's talk about testing. I'm a lab person. This is what I'm going to do. So let me kind of focus a little bit. Forgive the pun there. Focus on the bug. Of how we go about doing it. These are 3 ways that we can diagnose malaria. The gold standard, the best way to do it is microscopy. This sounds kind of old-fashioned compared to the others, but it's still the way to do it. It does require some good reagents, some good microscope, and it depends on some expertise. You have to have people who are good at preparing blood smears, good at staining blood smears, and good at reading blood smears. A lot of parts of the world, you really don't have that. But here we do. Should be available 24/7 on a stat basis. That's really the recommendation from the guidelines. We're going to do a couple different types of smears. You're going to look to see if you see those parasitic organisms, and then identify to the species level, if at all possible. We're going to do that by looking at the morphology of different stages of development. I'll show you some pictures there in just a second. The other thing that this lets you do is determine a percent parasitemia. What percentage of the red blood cells are infected by these organisms? And that's important to know. A very high level is not a good prognostic indicator. And then once you start on the antimalarial treatment, that number should go down very quickly. You should be down to undetectable levels within a few days. So it is important to watch that parasitemia level to make sure it goes down. We do always say, before you say that this patient is totally negative, we want 3 blood specimens collected 12 to 24 hours apart. We don't want you to send a single blood specimen for a malaria smear, and when that comes back negative, conclude that that patient does not have malaria. Yeah, you really want to go to 3. There can be low parasitemia. There could be some uneven presence of the bug in the bloodstream. So do 3 negatives before you say the patient's really negative. So I want to show you what these look like, because this is what I do. They call me in when they had a positive malaria, and I get to figure out what species it is. And it's kind of a puzzle. And to me, I'm a geek. It's kind of fun to figure out exactly what you got. You're going to look at a few different stages. This is the early trophozoite stage. This is one of the first stages that it's going to have inside that red blood cell. These are called the ring stages. They make these little rings. And the differences that you can kind of see here, won't go into great detail here, but you can look at the size of the rings. Falciparum has these tiny little rings. It's often going to have 2 rings in a single cell. The other rings are bigger. Malariae, Vivax, and Ovale all have bigger rings. It's going to be kind of hard to tell them apart based upon the size of the ring, but you can look at some other things. Notice here, you got all these little pink dots. That's common with Vivax. It's actually even more common with Ovale. And notice that the red cell is bigger than the uninfected red blood cells. That's not the case with Malaria. It's not the case with Falciparum. So you got some hints there. And notice with Ovale, the reason it's called Ovale is the red blood cells are often oval shaped. and often have this fimbriation, this kind of spikiness on it as well. So you get some hints. A lot of times you look at one of these and you have an idea. This is what I think it is. I got to look around and find some more before I really feel good about it. Then you can go to the mature trophozoite, this big kind of blob. These are kind of hard to tell apart. This blob here, O'Valley is kind of a blob too. Malaria likes to do this, make a band, like a belt across the red blood cell. And you can also get some hints here. Notice that this is bigger. This red blood cell is enlarged. This one is not. Okay. Falciparum, you just don't see those. Those are sequestered in the capillary bed, so you really don't see them. The next stage is going to be the schizont, and this one is kind of fun too, because you're going to have all these little dark purple dots. And the key to tell them apart is you count how many purple dots you get. Okay. If you get a lot of purple dots, more than 24, that's a falciparum, but this is very rare to be seen in the peripheral bloodstream. 12 to 24 is a vivax. Less than 12 could be one of these two. Okay. So also notice, just in case I have time to mention it a little bit later, probably not, but this brown goop, okay, notice that they all have this little brown stuff in it as well. It's called malarial pigment. You want to see that too. And then the last stage is the gametocytes. This is the one you like, falciparum, because he's classic. The banana-shaped gametocyte is classic as soon as you know that you got falciparum. The other three are very difficult to tell apart. They're almost impossible to tell apart. But you get some hints from the size of the cell, those little pink dots, the shape of the cell with the fimbriation, those little pink dots, and the fact that it's a clean cytoplasm, no pink dots, and not enlarged. So you got some hints to look at. So anyway, that's what we do. When we get these smears, we know there's a parasite, we'll come and we'll look at it, we'll kind of go through the whole thing, try to figure out what species it is we have. Then we know if it's falciparum, we need to worry about the severity of the disease. If it's vivax or O'Valley, we need to worry about properly treating the cryptozoite stage. So that is all important to know. The other thing is important to know is the percent parasitemia. So this is just a diagram showing here. You count the number of infected red blood cells, divide that by the total number of red blood cells that I see, and that gives you a percent parasitemia. And remember here, this is a hint too, because if you got more than, say, 2% parasitemia, it has to be falciparum. The other ones are never going to get above a 2% parasitemia. So that's a big hint as well. Okay, that's microscopy. Let me hit the other couple of ways. Rapid antigen testing. This makes perfectly good sense that we should be doing this, right? You know, just take a blood specimen, put it on this little strip here, and watch for the bands to show up. This will distinguish between falciparum and non-falciparum. It doesn't go into details about the other species. It just says falciparum or non-falciparum. These tests have been around for a long time, but they're used almost totally in Africa. It's approved here in the United States. Very few labs actually do it. It's not as good as microscopy. It's not as sensitive. It's not going to allow you to determine the percent parasitemia. It's just a way to make a rapid diagnosis when you do not have microscopy available to you. So while it sounds like a great idea, it's really not something that's widely used in the United States. Mostly going to be used in underdeveloped parts of the world where malaria is endemic. Now, what about PCR? Hang on, if I can get this to go. There we go. What about PCR? It sounds like PCR would be a great thing to do, and it's got some good things. It's good when the percent parasitemia is very low, because there you can look around a slide a whole lot and find very few examples of the parasite. It's good if you don't know what species you have. If I can't really tell from the morphology, we can do a PCR to tell which species it is. And it's good for mixed infections. The mixed infections are not uncommon, and they're really difficult to tell from a microscopic perspective, because you're looking around and trying to take the different morphologies and put them into one species. If there's two different species there, it can be very confusing. But it's not going to be used much in the US or anywhere. There's no commercially available test. There's no FDA cleared test. This would all have to be a laboratory developed test on its own. You're not going to be able to do it stat. And it does not correlate to percent parasitemia. It's going to measure bugs that we would not count for percent parasitemia. So you can't use it to follow treatment. So in other words, it's got specific purposes, but it cannot replace microscopy. So even after all this molecular revolution, all this development of rapid antigen testing, the best way to diagnose malaria is still going to be microscopy, and that's still going to be what we rely on. How much time do I have? I'll skip that. One of the reasons I wanted to talk about malaria is because there has been some news in the past couple years. And I want to bring this up right here. They have been searching for malaria vaccines for decades. I remember when there was so much excitement about a new vaccine that reduced the incidence of severe malaria by 1%. They were freaking out. Oh, wow, great. But obviously that's not enough to make it worthwhile to do. That's not the case now. We have some decent vaccines that have just become available. These two vaccines have been approved. Both of them reduce malaria cases by more than 50%. The idea here is we're going to give these to the kids in endemic areas. You can't give the kids prophylactic medication. The medication that we give to travelers, it's not practical to give that to people living in Africa and say, take this every day for the rest of your life. We need a vaccine. And the vaccines here seem to do a really good job. So the idea is give it to children to reduce the incidence of severe malaria. You're not going to stop malaria from occurring. The number of cases is probably going to stay up there. But the deaths, the mortality from malaria should come down. These seem to work really well. So there are now 10 countries in Africa where this is now routine part of the childhood immunization program. 15 more expected this year alone. And there's another group of countries that are looking to provide it afterwards. The manufacturers say there is no problem meeting the demand. They will be able to produce enough of these vaccines. So we're going to see some huge changes in malaria statistics coming out of Africa coming up in the next few years. Be interesting to see. Now, we told you, we used to have a lot of malaria in the United States, and it just kind of went away. This was 2003. I think this is Broward County, Florida. 8 cases of locally transmitted malaria in Florida occurred in 2003. Okay, 2004, there was none. 2005, there was none. 6, there was none. There wasn't any other locally transmitted malaria until last year. And in last year, we had 7 cases in Florida, 1 in Texas, 1 in Arkansas, and 1 in the Washington, D.C. area, all locally transmitted. So, it's not unheard of. At some point in the future, we may be saying, if patients come back from Florida with a fever, then we need to consider malaria as a possibility. It's making its way back. We can blame climate change. We can blame a few different things. To my knowledge, there has not been any locally transmitted malaria in the US in 2024. But we'll see what happens. I did want to show this map just to finish things up here. If you're thinking, we're not worried about it, we don't have the mosquito here. This is the range of different species of Anopheles mosquitoes that are known to transmit malaria. And this quadrimaculatus, Anopheles quadrimaculatus, which spreads over the entire eastern United States right up to Newfoundland, is a very efficient transmitter of the malaria parasites. So the mosquito is definitely here. I think the reason we don't see more widespread transmission is that the mosquito has got to stay fairly warm in order for the parasite to finish its life cycle, the stages of development in the mosquito. So for example, falciparum, if it gets below 68 degrees, he's not going to be able to finish his life cycle in the mosquito. Vivax can do a little bit cooler temperatures than that. So I think we'll see a situation as we get warmer and warmer and warmer, and I believe it's going to be greater than 68 degrees today in Louisville. That we may see a continued more transmission taking place in the United States. In which case we're going to have to change the way we deal with fever. Can you imagine anybody who's had fever and has been anywhere south of the Ohio River needs to be checked for malaria? Let's hope we don't get to that point. Anyway, while you're out and enjoying the warm weather in your shorts and your t-shirts, sitting outside on your deck as the sun goes down, just watch out for those mosquitoes. Okay, that is all I've got. If anybody has any questions, I'll be happy to try to answer those. What you got?
I don't have any questions. I think it's just absolutely staggering, the pediatric mortality rate from something like malaria. And I have yet to find like a really good reason for mosquitoes. So I'm still looking. I'm sure there's something out there, but they just seem to transmit a lot of illnesses.
It is, you look at it and say, what would go wrong if we could completely wipe every mosquito off the face of the earth right now?
Right. Where's the negative? I'm sure there is one that I'm not familiar with, but
it sounds like some kind of novel. I need to work on that novel, wipe out all mosquitoes, and all of a sudden something's going to go haywire in the ecology.
Yeah. Well, it's going to be really interesting, I think, to see, to your point, vaccine uptake and what that impact has, particularly if, to your point, it does move further, or the incidence increases in the United States, what that looks like.
Well, I think one of the interesting things about the childhood vaccine in Africa is, okay, we prevent these severe cases in children. Then we stop vaccinating them. How long does the immunity last? Are we going to start seeing severe cases of malaria in adolescents in Africa because, we prevented them from getting, you hate to say it, but you prevent them from getting the disease that's going to give them immunity for the rest of their life.
Yeah. Interesting. Well, it'll be interesting to see. So, I don't see any questions in the chat. I did see a number of hand claps. So as always, thank you very much for your presentation. And next week, we will have our colleagues from pharmacy, and they're going to be talking about an overview of the new pharmacological strategies for CDI recurrence. So look forward to that. And in September. Everyone have a great day.